Medications for opioid use disorders in correctional settings. Shifting the paradigm, creating a balanced correctional and rehabilitative approach. The Opioid Response Network is funded by SAMHSA to provide resources and technical assistance needed locally to address the opioid crisis. This video is part of a series to provide guidance on the implementation of medications for opioid use disorder in correctional facilities. Leading corrections and behavioral health experts present information on topics such as the use of medication, models of delivery, diversion, and linkages to care and community support. Linda Hurley, Tara Flynn, Rachelle Steinberg, Dustin Alvanas, Jennifer Clarke, and Richard Brathwaite discuss models of delivery.
As I mentioned yesterday, this is a public health and a public safety priority, and we all know that. I'm talking to the choir here. But one of the things that's also happening with the Opioid Response Network is that we're working on another project that I thought might be useful and helpful for others to know about. While we're working with the judges to start with, we wanted to start with the judges first to kind of get buy-in, get support, and get their leadership. Because as we know, if a judge wants to convene a group of people in the community, people come. So a judge says to me, I ask the head of the jails to come. I ask the hospital agent. I ask leaders in the community to come. People typically come when a judge tells you to come. And so we want to try to empower them even more so and let them know that they don't have to be a clinical expert. We don't want them to be clinical experts. We want them to connect with people in their community who can join forces with them and, again, connect the dots and find out how we can support one another. So we have a project called Justice-Involved Individuals with Substance Use Disorder. And let me just clarify, this is not to make everybody to have specialty courts. This is not to make we're trying to get all the medical people to become addiction specialists. This is mainstream foundational level education and training. What is the information and the skills that we need to have to make better choices and decisions? So many years ago, probably 12 years ago, when I was at Brown University at the Center for Alcohol and Addiction Studies with Rose and some of the others here, I worked with a think tank of Surgeon General, Secretaries of Health, Deans of Majors, law and medical schools, and focusing on promoting evidence-based practices. And it was translating science into how we can prevent and treat substance use disorders and not focus so much on incarceration only, and having those people be the messengers. We developed a resource guide. So again, Opioid Response Network is funded by SAMHSA. The first thing that we wanted to do was take what we learned by working with this think tank, Physicians and Lawyers for National Drug Policy, and build off of that, because that was 12 years ago. And while we knew that it was a huge effort, the community wasn't really ready for it. The opioid crisis had not hit. Now, while there was addiction going on and people were dying, people were not ready to hear it. The people were like, we don't deal with those patients. We don't want those people. Stigma, stigma, stigma. Well, there has been a shift, and people are saying we have to. So we wanted to bring back the resource guide and go further with that. So we met with the chief judges of the country. We've joined a relationship with them. We brought the National Judicial College in that trains all state judges. And we formed a collaborative effort. These chief judges of the country released a task force report on opioids. And so we're joining with them. And then we also ask every chief judge in the country to identify one judge in their state to be their champion. Now, this doesn't mean that they have to know everything about everything, but this is somebody who believes in this already. You don't have to convert them by any means. We got 46 judges to come to Reno to the National Judicial College for 3 days. That's a huge effort to get them to come out of their courts and to sit with us and to talk about how can they be champions to help spread the word, not only with their colleagues, but also with policymakers within the community, because for them being the messenger, again, people listen. So we had them come for 3 days. We talked about what are the evidence-based practices, what do they need to understand and know, how do you explain it's not a drug for a drug, how do you dispel the stigma, and so forth. Simultaneously, what we're doing, we're also taking the resource guide that we had developed years ago. What are the medical aspects of what everybody in the justice system or anywhere need to know about addiction? What's the neurobiology of addiction? In plain, simple terms. A lot of the judges were like, oh, I don't do science, don't talk about neurons and synapses. They're like, nope, I'm not there. So we really boiled it down to make it understandable. We also talk about urine drug testing. You know, how is it used? How can we make sense of it? How do we interpret it? But then also how to form collaborative relationships in the community so you can come together unified in a public health and public safety. The second thing, the third thing that we're going to do is we're developing an online course, and it's going to be free, just like the resource guide, and it's going to be for everybody in the country. So it's not just judges, but we started with the judges, and we're going to expand out beyond that. And also, it's not just the judges getting educated. The medical community needs to learn about how to work with the justice system and the legal community. So we've been working with doing training for in our organization for the American Academy of Addiction Psychiatry, and we've developed, we had a one-day course on training addiction specialists on what they need to know. And then we are working on building a forum for judges and other people in the legal community to be able to pose confidential questions to addiction specialists to get information and resources on educating them as well. So the Judicial College, as I said, we had 45 champion judges to come. Collaboration is key. Stigma is huge, and how we can help them help spread the right word. We had a buzzer that would go up every time somebody said the word addict or clean or dirty, and it was like, whoa, don't say that. And the judge was like, okay, we can't say that. And it was really, I mean, it's a culture change, but it's also recognized to acknowledge that we come from different perspectives, but we have common ground. And I think that was really huge because the judges were like, I can't get doctors to talk to me. And doctors are like, I don't know how to talk to judges. So it really is laying the groundwork for how can we locally get your champion judge in your state to connect with other people in the community like-minded to help address these issues. And so I think you're going to see more and more because the chief judges are, I mean, they're rock stars. They are like, we're going to commit to every judge being required to have so many hours of training in substance use disorders. We're going to have all these other expectations. So they don't sit around and pontificate about it, they push. And so the chief judges are very committed to this. So education is key, and we want to help support that. And so I wanted to let you know about this because I think this is going to be useful information. Again, it's all free. It's going to be online, so we can maintain it, keep it current, and that it's going to be available to everybody. And we did start with judges, but we want to go this much broader to everyone in the legal community, and then network out to resources and models that might be helpful. And of course, bring in Rhode Island. But there are lots of people that are already developing repositories of models, so we don't want to recreate the wheel. We just want to make sure that with basic information gets out. The course will be based on the Reno training, but it will be modified to be much briefer. We don't want to have 3 days of online courses, but it really will hit the high points of what we feel is necessary and important. That's it. And when is it going to be due? We're hoping in the next month we have the resource guide, and we hope to have the online course out in the next couple of months.
Thank you, and I assume those will be on opioidresponsenetwork.org. Okay, thank you, Catherine, for the presentation this morning about the Medicine and Justice Initiative.
Well, good morning. As we get settled here, I actually gave myself notes because usually I'm kind of tangential and we don't have time for that this morning. We've decided that we're going to try to leave a full 30 minutes for questions at the end of this plenary presentation. And the reason for that is that you have right here a tremendous resource at this table. These folks are from 5 actually different settings where evidence-based models have been implemented, but have been implemented in various ways that are reflective of the access in their community, the geography in the community, and the number of people that need this service. So we're very excited to have that available to you. We have Norfolk County, Suffolk County, and Hampden County represented from Massachusetts, as well as Rhode Island. So our goal is to present models of delivery based on the principles of what has been proven to be an effective enhanced medication-assisted treatment, or MOUD, treatment including MOUD, sorry. And to show that regardless of resources, regardless of population, regardless of geography, there are ways to begin to apply these life-saving principles to the care and move forward. The principles are very simple, really. It's to provide, whenever possible, all FDA-approved medications so that there is participant choice and buy-in in the medicine that they're actually getting. And Dr. Clarke here is quoted everywhere as the best medicine is the one that the individual will take. So that there needs to be options for that to occur. The medicine needs to be available to everybody that needs it when they need it. And when we're looking at correctional settings, that's a little bit more difficult than it sounds, correct? So that's been a real challenge. There needs to be the psychosocial supports, the counseling, and what is critically important is all of that continues with wraparound services upon reentry. So it sounds like 5 very simple little principles, but in actuality, they are impacted by the variables, the geographic variables, the political will variables. We could spend all day naming those variables that are challenges, but we have a lot going for us. And what we're going to hear from right now, who we're going to hear from right now are going to tell us how they have successfully implemented different models. We're going to start, and if it's okay with everyone, just to save time, if you could introduce yourselves as we move forward, that would be great, okay? And so I will introduce Dustin Alvanas, who is the Vice President of Operations for CODAC Behavioral Health Care and has been integral in the development of creating opioid treatment programs, so much so that I brag about him, and he will be on our next pamphlet as being able to create an OTP in 90 days. There goes, oh God, because we're looking at what? DEA, CSAT, accreditation, state licensing, and state pharmacy board. 5 that, and I think that Dr. Pote yesterday referenced that, but he's got it down to a science. So Dustin, if you would like to, why don't you pull that over? That makes it a little easier, if you don't mind. Thank you. And Dustin's simply going to give you an idea of what to think about for your questions as you listen to the rest of our panelists present their different operations. I have the clicker. I am clicker charged.
Okay. So like Linda said, I'm here representing CODAC Behavioral Health Care. We're a vendor for the Rhode Island Department of Corrections as well as Hampden County. Is just to get an idea of the audience, how many of you are from an OTP? It's looks like only 3 or 4.
How many people are actually working in an opioid treatment program? Hi. There we go.
Right.
Yeah.
So these considerations are really for you. These considerations are for the vendor moving into the Department of Corrections, what considerations you may want to make. So there's only 2 slides, but CODAC as a vendor, these are questions we'll ask ourselves when we're moving into Department of Corrections as to what model we want to choose for delivery of the medication.
Excuse me, Dustin, would those considerations also apply to correctional institutes who want to license their own, like Franklin County has?
Sure.
Sure. So it goes across the board.
Yeah. So the first thing we'll consider is the expected population size. So if, for example, if you have an anticipated census of 300, it's going to be administrative, security, and resource concern to transport those patients to a community OTP, I would assume. Also, you need to consider your distance to your nearest community OTP. So for example, CODAC, our nearest community site to Hampden County is 80 miles away. So I don't think, I'll ask Rich, I don't think that they'd be very comfortable with transporting patients, or the DEA would be very comfortable with us transporting medication 80 miles every day. No. Sorry. Forward. You have to anticipate the layout of the DOC. So the medication movement throughout the administration sites, how many different buildings they are, how far apart they are, who's going to be responsible for the transportation of the medication, and consider the MAT population at each site. The scheduling of the medication lines is something that we learned, we kind of learned the hard way through experience in Rhode Island. But you need to consider if there's a population that needs to be medicated prior to either being released for a work duty or going to court, because we have to assure that we're going to provide the medication to those folks on a daily basis at a similar time each day. And one thing that we learned, lesson learned by moving into a DOC setting is the DOC itself operates off of security and scheduling. So to go in there and think that you're going to have a med line at 10 o'clock one day and 11 o'clock the next day, it's just not going to happen. It's not feasible. Determining your own staffing configurations is just considering your resources. If you have staff that you can, existing staff that you want to use, if you're going to be treating a small population, you can use your medicating nurses. Two different models that CODAC has as a vendor is we transport the medication, or sorry, we dispense the medication inside the DOC, and the DOC nurses in Rhode Island actually do the administration. And in Hampden, we have a different model where we actually administer as well as dispense the meds. The IT system integration deals with your electronic medical record. So as a vendor, you just need to concern yourself with whether your EMR can speak to the EMR of the Department of Corrections, whether it's necessary, where you're going to be documenting your case history and your notes, and are you going to have a hybrid chart, a paper chart, or electronic chart? Just a consideration. The big one, licensing, as Linda brought up. If you opt to operate an OTP inside a DOC, or if the DOC opts to form their own OTP, you're going to have to get state licensing. Your Department of Pharmacy will issue your controlled substance registration. Your DEA, your regional DEA, your regional DEA will issue you a license as a narcotic treatment provider. And finally, then SAMHSA will issue you your OTP license. And we know that with licenses come audits, renewals, site visits, licensing reviews, and licensing leads right into accreditation. So to be a licensed opioid treatment provider, you need to be accredited. And with accreditation, that would be the responsibility of the vendor. So if it's something that you want to co-locate an OTP inside a Department of Corrections, you have to be ready to be accredited. As for medication inventory, it's just deciding what types of medications you're going to provide, whether it's all three or only two of the three. You have to worry about the movement of that medication throughout the DOC. And the associated costs of the dispensary are huge. This is a huge one, so this really lays into your budget concerns, because you have things like the safe, the pump, the equipment, the licensing, the electronic medical record, the alarm system, which the DOC is going to have to monitor for you. So the associated costs with a dispensary alone, without build-out, could be upwards of $20,000 before you even put a nail in the wall. Most importantly, with choosing a model, though, it's going to be whatever works best for you as the vendor and your relationship with the DOC, and really what's going to be the best model to treat the patients.
Thank you. If, just an additional, when we come to talking about the DEA, there is supposed to be a publication, and many of you may know that we've been waiting on that publication for decades, well, not decades, I exaggerate, but for a wicked long time. And it was anticipated in the end of December, and it may be out by the end of March, which may clear up some of the regional disparities that we see, because there's folks here from all over the country, and there's a lot of interpretation that occurs in the registration of DEA-approved OTPs regionally, which can be very confusing. That's why we didn't want to get into too much detail. Is there anybody from the DEA here that isn't afraid to raise their hand? We're really a nice group, we are. Okay, thank you. Rich.
Good morning, and greetings from my sheriff, Sheriff Dick Cochee. And I'd like to acknowledge my medical director, Tom Lincoln, who's sitting in the front here, and my colleagues and the CODAC team. I'm the Assistant Superintendent of Health Services for the Hampden County Sheriff's Department, located in Ludlow, Massachusetts. We operate 4 residential sites and an aftercare facility in Western Massachusetts. In our Ludlow facility, we're mainly male population, and we're handling clients' pretrial and sentence, also regional lockups and safekeeps, and also the DOC step-down populations, and also a Bureau of Prison folks re-entering into Western Massachusetts. We have a work release program, which is a quarter of a mile from our Ludlow site in Ludlow, which is a 35-bed site. About 16 miles away, we operate a regional women's correctional center in Chicopee, Massachusetts, and we serve populations Worcester West and the Hill Towns. We also have a wellness and recovery center, which is located on Mill Street in Springfield, and that's also a 145-bed site, in addition to our aftercare facility. Our current census is around 1,200 total population. What we see in Hampden County of our population coming in, 90% of those entering our walls report a substance use disorder. Of that, about 40% reports an opioid use disorder. So it's been motivating for us to go in this direction, and we've been providing treatment for over 7 years now. In the past, it's been mainly naltrexone and the Vivitrol we've been working with, in addition to methadone for a pregnant population at our women's center. Over the years, over the last 3 years or so, we've introduced buprenorphine for those folks that had come in and need the treatment. So for us, as we were exploring what we're going to go do and what what direction we're going to go regarding the opioid treatment epidemic that we dealt with in Western Massachusetts, we sort of cast a broad net and look at who's been out there in the field. And we settled with CODAC, who is the administrator for the Rhode Island Department of Corrections, based on the fact that they had correctional experience in working with those with opioid use disorder. So for us, we also explored the option of bringing folks out to vendors, and we settled on having our opioid treatment program within the walls of our correctional setting, based on all the roadblocks and complication with providing services for approximately 1,200 patients. For us, the mode of delivering the services to our 3 residential sites, in addition to our main campus in Ludlow, which the dispensary is located, we took the pathway of everyone's dosed at the correctional site in Ludlow that are on the campus, and we carry out medications with an armed officer or nurse to the other 3 locations in Chicopee, Mass., which is about 16 miles away, the Women's Center, and about 17 miles for Springfield for our Wellness and Recovery Center, in addition to or pre-release, work-release program, which is a quarter of a mile from the main campus. So that's been working for us currently. It's been going well in addressing the issues that we see and treating the populations that we deal with on a daily basis. So I think my 5 minutes is up.
Rich,
Thank
I'm
you.
sorry, I may have missed this, but what is your role at,
I am the Assistant Superintendent of Health Services.
Yes,
For the Hampden
okay.
County Sheriff's Department.
thank you. And a couple of things that you mentioned there. I hope you heard the geographic scope of the services of Hampden County, and that's a variable, as Dustin said, in creating your system, and that's very important. And also the staffing, if you are looking outside for vendors of any kind, I believe that you're going to find that finding a vendor or a partner who has experience and understands the missions of corrections is going to show much more quickly and much more effectively positive outcome. Because one of our biggest challenges was integration of mission. You know, you come in as a treatment vendor, and so the mission of treatment and the mission of safety and security, there needs to be mutual respect and understanding. And that is critical, and that requires professional maturity. These are not positions that you fill with entry-level folks. Thanks.
If I can just mention one other thing.
Sure, please.
And this has all been driven in Massachusetts by the CARE Act, which I forgot to mention. And we have 7 pilot sites in addition to the Department of Corrections that's in the pilot. Since September 1st, which is the enactment of the CARE Act, we've serviced 530 patients with all FDA forms of MAT. Currently today, we're at 151
Nice.
patients being dosed at our sites, and we have about, there were 92 on buprenorphine, and we're around 61 on methadone, and we had 2 Vivitrol patients today. So, thanks.
Good morning, I'm Rachelle Steinberg. I am an Assistant Deputy Superintendent at the Suffolk County Sheriff's Department in Boston, Massachusetts. As Rich, my colleague, stated, there are 7 counties in the Department of Correction within the state of Massachusetts that piloted an implementation in September. I keep telling everyone that's not a pilot. This is not going anywhere. It's just going to continue.
Thank you.
Tara to my right is one of our other counties, and the 7 counties have been working together very closely over the last year and a half on figuring out how we can do this implementation. Massachusetts is a different correctional setting than most states, than all other states. It is a 3-tiered correctional system. You have jails and houses of correction that are run by sheriffs that are elected, and then you have the Department of Correction. So it's very different than other states. And being in a metropolitan city adds that a layer of difficulty to that. Suffolk County has 2 facilities within Boston. One is a jail, and that is all pre-adjudicated pretrial men. We have 1 sentenced unit there of workers, but it's all men. On average, there's about 550 men there a day. And then we all have another facility, the House of Correction, that's on the other side of the city, that houses males and females. Rich and our county, Hampden County and Sheriff's Suffolk County, are 2 of the fewest counties that house females. Most of the counties in the state of Massachusetts do not house their own females. And as Rich said, he houses many of the women from Worcester West. We actually at Suffolk County now have 4 counties of females, which started during this whole implementation phase, which skyrocketed our numbers. We, in September, only had Suffolk County females, as well as our men. In October, we began taking 3 other counties worth of females in about a 3.5-4 week succession. Our MAT numbers at that point jumped and over doubled. So that was a very difficult task to manage in terms of all of this implementation and going through the hurdles of the medications we are providing. When we were all meeting over this year and a half of planning, every department was trying to figure out what was going to work best for them. And Some of our other brother and sister agencies have a lot of property. Being in the middle of a city, we didn't have places to expand. So creating an OTP and being able to offer all forms of MAT inside our 2 facilities did not seem as an option at that time. So we needed to seek other avenues in how we were gonna support all 3 forms of MAT. We had been working for years with one of the 2 methadone clinics that literally reside outside our front and back doors of our institution for pregnant females and their methadone. So we felt that that was the best option for us, is to continue to transport our men and women to the methadone clinic across the street every day, and continue that process. Our men that are coming in with verified methadone prescriptions at Nashua Street Jail or the Suffolk County Jail, which is in downtown Boston, are actually transported and transferred that night after booking to the House of Correction so that they can be dosed the following morning. The couple issues that we have come across are some of the other clinics trying to find out and verify their dosing has taken a little bit longer than we've expected. As many of you know, if you're working in clinics or certainly in OTPs or working with them, a lot of times the clinics close early. They stop dosing anywhere between 11 a.m. and 1 p.m. So to get verifications done and to get people transported and dosed can become a little bit of a hurdle. We are fortunate because the clinic we are using is literally across the street of one of our parking lots. So for us to get our men and women there, generally we can make it there before their ending of dosing, and we've been working with them for a number of years, so that relationship continued and has continued to build with the men and women that we have on methadone. We did not expect our methadone numbers to increase as much as they have. Today we have 29 people on methadone. We used to transport 1 or 2 a day, maybe 0, and now we're 29 and counting. We have a total of 1,350 on average men and women in our county a day. About 12% of those are on MAT. Since the implementation, we have, as I said earlier, over doubled our population. We have we've served over 600 people, and the amount of doses has incrementally jumped. I sent some data to my treatment coordinator who was in the audience yesterday, letting her know that our numbers had literally doubled by 2,000 from October to November. And that was with the implementation of transporting all the females to our population. 84% of our men and women are on, not 84%, but 84 of those men and women that are on MAT are on Suboxone or buprenorphine, Subutex combination, about 16% on methadone, and that slight on naltrexone for Vivitrol. As Rich stated, most of our facilities in Massachusetts have been doing Vivitrol for 5 to 6 years. So that is something we continued and sort of reformatted how we were going to do everything. Working with our clinic offsite for methadone only has worked out well. The clinic has been incremental in helping us with managing the programs. Their staff is actually coming inside our walls to do their required groups for the methadone population, and we're working with them on implementation for those that would like to be inducted on methadone, and working with the men and women outside in the communities to make sure that they have a clinic to go to. HCRC, Healthcare Resources Centers, is what we are currently partnered with for methadone, and then everything else is done inside our facility. We actually have 3 simultaneous med passes going on throughout our 2 buildings at once, 1 at our jail and 2 at the House of Correction. As Dustin said earlier, these med passes can take a long time. The process we're using is a cross between what Rhode Island has put in place and what Franklin is putting in place. But our med passes take probably 3 to 4 hours. So those looking to implement, we have worked through a lot of hurdles. I'm sure that I speak for all of us to reach out and ask any questions. We're actually changing our shift times to accommodate our med passes, and we will, in the next couple months, be starting at 5:30 and 6 o'clock in the morning versus the 7:30 hour. In order to get our med passes complete before programming, we are also getting everyone dosed, obviously, before court and before releases, and that's a challenge as well. So working with our captain that is helping me oversee all of this, as well as our multiple officers, in working out the kinks as we go through it. But we started off with 1 med pass at the House of Correction, and within 3 weeks jumped to 2. So we needed multiple nurses, multiple officers, in order to get the med passes complete. Thank you.
Hi, I'm Tara Flynn, Norfolk County Sheriff's Office. We have an average daily pop of 450. We are an all-male facility. As Rachelle said, we've done Vivitrol since 2014. We started with the Suboxone and Methadone added on September 1st. To date, we have served 354 patients. As of today, we have 65 on Suboxone, 12 on Methadone, and 2 on Naltrexone. We partnered with Spectrum Health Systems because our Methadone numbers are pretty low. So they come in every day as a visiting nursing model. So we're a little different than the other 2 facilities. Let's see. We have weekly team meetings, which include medical, mental health, security, and recovery coaches. And other than that, we do the same process with our MedPass daily for Suboxone. So pretty similar, just the only difference is the methadone aspect.
Thank you for that, Tara. And I think it's interesting. You can start to hear how there are similarities and the work is getting done according to best practice principles, but the operational component reflects the variables in the community. And it's wonderful to hear the creativity. So thank you very much. And Dr. Clarke.
Thank you. Hi, I'm Jennifer Clarke from Rhode Island. We started our program about 4 years ago. I've been in the Department of Corrections for over 20 years, but became the medical program director right about the same time that we started the MAT program. So it was a pretty steep learning curve with many different issues. But the MAT program, it really gave us a good chance to work with security. So I think it bridged a lot of gaps that we'd had in the past between medical and security. In Rhode Island, as everybody, I guess we've been saying a lot, we're very small, tiny. We're all on one campus, so I can walk to every facility. There are no county jails, which facilitates things. It can be a little bit of a challenging, but it also is something to take into consideration when you're developing your program. So my goal today was to listen to what everyone else said and then tell people about all the things that we did wrong, so you don't have to.
Except for selection of partner.
So first thing, I thought we would want to get the license. I thought the DOC, more I heard about the amount of work involved, and with so many things, I'm like, let's have CODAC do everything as much as possible. It was much easier for us. It might be different in your system. We're up to, and I was pretty good in estimating before we started. I thought that about 350 people would need treatment, and we have about 350 people on treatment right now, with about 100 being released every month on treatment. Again, the combined system, jail and prison. One thing that I didn't think about at all, really important to consider, if your system has a union, work with them early, frequently, bring coffee, bring donuts.
And helmets.
It was very stressful in the beginning. We now have a very good understanding and are working very closely together. CODAC comes in, they have a licensed room. It's a dispensary, but it's really like a large closet for things. That's their area. Security does have access to the key, but it's only the deputy or warden that can get it. So it's really their space within the DOC where they dispense all of the medications, and then our DOC nurses are administering the medication. Again, we had to work out a lot of issues, so talking about it early, coming up with a clear understanding of who's going to do what is very important. Patient issues that I didn't think of early on, out-of-state transfers. We had people on 80, 100 milligrams of methadone that we didn't think about planning for the transfer out of state, and then working with the other state to try and have somebody stable on their medication. A few states have said, they haven't taken the patients, and we've kept them for their full sentence. Work release, I didn't think about at first. We started off the program saying we were going to keep people on for 6 months to a year. That was not ideally what I wanted to do. I thought everybody should just continue on the treatment. We slowly built up the time that people were on treatment. What we found was by limiting it to 6 months to a year, people would have good time. We wouldn't really know when they were getting out, so we would have people where we were weaning them off treatment just to put them back up, so we extended that time to 4 years. That, I think, treats about 98% of our patients. It's the very few people get a longer sentence that need MAT, and as we heard yesterday, we'll see where those lawsuits go, try and stay ahead of them, but I have a feeling eventually we will be beyond the 4 years. Court lists, that's another big issue. We didn't think about people getting out at court, trying to get the doses in before people go to court, working with CODAC to get them the court list. It took a lot of coordination. And what's available in the community it was also a very important consideration. Again, Rhode Island being so small, we have, CODAC has sites throughout the state, so we were very lucky with those individuals that a lot of people, almost everybody is close to a methadone program. Unlike, I think most other sites said they have more people on buprenorphine than methadone. We actually have more people on methadone than buprenorphine, and I'm not sure if it's because it's easier in Rhode Island, again, because of the distance. I know for a lot of people in Mass, it might be a 2-hour, 3-hour drive. Nothing's more than 45 minutes away from you in Rhode Island, unless there's traffic. And then working with patients as individuals and really understanding the reasoning behind their choices for treatment. So we have all 3 types of MAT available. I had a patient early on. She told me she wanted to be on methadone, which I thought was a little unusual. She was in her early 20s, had only been using opiates for about 6 months. It seemed like buprenorphine would be an easier option for her. So I asked her about it. I asked why, and she was like, she just knew she couldn't handle the responsibility of having buprenorphine with her. She knew she'd be too tempted to sell it and go back to using heroin. So we worked with CODAC, and she wanted to go to a place every single day. So we made that happen with the medication that was most appropriate for her, which she decided then was the buprenorphine, and really working with each patient with their needs, what's available in the community, because not every community is going to have a place where a patient can get buprenorphine every day. So my time is up. So leave it there. Thank you.
It isn't. I have more questions. No. One of the things, just to follow up on what Dr. Clarke said, is that as you heard, this has been a remarkably thoughtful process, and I can never present with Dr. Clarke without saying that she is just a force to be reckoned with when it comes to patient care, participant care. I mean, she puts, for those of you old like me, she puts Henry Kissinger to shame around negotiation skills and a little bit of Machiavellian stuff tossed in. But she's amazing, so thank you for what you've done for Rhode Island. In terms of reentry, I want to just touch on a little bit and then ask each of you a question around that. One of the benefits we have in living in a state shaped like a peanut and the size of a peanut is that we do have, I think we have 14 opioid treatment programs in the state. 7 of them are CODACs. So what makes that really helpful is that the individual, when Dustin talked about electronic health records, the individual, while they're incarcerated, becomes a CODAC patient. So at the point of discharge, or the point of release, sorry, one of our deliverables is truly to have the individual have care the next day, be able to have a flawless, seamless, and we all write grants and everybody says seamless. We really do have a seamless system. Now, it doesn't mean that all of the individuals that are re-entering the community have to come to CODAC. Very, like you spoke earlier about someone wanting to receive buprenorphine as their medicine from their doctor in their home community. The discharge planner can call up and say, Dr. Jones, Linda's going to be out tomorrow, and Dr. Jones's office person will say, yay, we can see her in 3 weeks. Right? So what happens to Linda when that happens? So what CODAC does for any of the medications is we actually, when they come out into the community, they can walk right into any of our sites, and there's none of that difficulty that you guys might have recognized at times where you'll have an office say, yeah, we really want her back, but we don't have an intake appointment until Thursday or Monday. And we always shiver at that because we know what each 24-hour period means upon reentry. So I think, if you're looking at creating a program, it's critical to look at every piece of what's happening inside, because you want evidence-based programming because we know it's effective. And if someone leaves and has nowhere to go, all that effectiveness has really lost a lot of its impact on someone's life. So if I would just like to hear from any of you guys around reentry, what the challenges are and what you've been up to.
I just wanted to add to that in Rhode Island at CODAC, we dispense buprenorphine as well. So it makes it a lot easier, whereas we've noticed in Hampden County, a lot of the other DOTPs in Massachusetts do not dispense buprenorphine. So we have our medical director up front that bridges scripts for folks. So it makes it a lot easier that we're able to provide that continuity of care without having to bridge the prescriptions.
Thank you.
We've noticed, and again, working together as a collaboration with all the other counties in the Department of Correction, with the way the pilot was rolled out, there were some unintended consequences that we've noticed. There are 13 counties in Massachusetts. Only 7 of us are doing MAT. So similar to what Dr. Clarke said about people getting transferred to other county facilities or other states for that matter that may not be doing MAT is a little bit of a barrier, especially for those that came in on a prescription that we're maintaining. When they're going out to another facility or wanting to be inducted on that medication, we have to look at all factors before we even give it to the medical teams. So that is something we're dealing with on a daily basis. Tara and I talk about this probably on a daily basis. The other factor is that the majority of our population are pretrial. They're pre-adjudicated, pre-sentenced. So we don't know what's going to happen with them. And no matter all the work that we do, we have remarkable wellness navigators that are working with the men and women that are on MAT or wanting to be on MAT and part of our treatment programs, that are working with them with treatment plans and discharge plans. But we don't know what the court's plan is. And we have a number of specialty courts and drug courts in Suffolk County, which we're fortunate to have. And our wellness navigators go to those drug courts or recovery courts on a biweekly basis. So we know those that are working with the specialty courts and to what the plan is for them. But we have a lot of men and women who don't show back up after court that day. And we don't know where they showed up. Our medical vendor, I have worked with them over the last bunch of years to make sure that medication is there for them when they come back. If they come back, we'll save them for about a week for them to have. We also are writing bridge scripts for the men and women that are on bupe so that they can get to their next appointment. But the pretrial population is the biggest barrier we're finding because we don't know when they're leaving. And to develop a plan and to make sure that they have appointments made is very, very difficult. For those that are leaving, when we know they're leaving and they're leaving free and clear, maybe on parole or probation, making appointments for them, can be a challenge because some of them don't know where they're going to be or if they're going to a program, working with that program specifically. But being able to make appointments enough in advance and with those bridge clinics, bridge scripts, my apologies, have assisted, but there is some challenges. I would say to anybody or any state that is looking to roll something out like this to make sure that everybody is on board. I think that the OTPs, there needs to be a lot of conversations ahead of an implementation. Absolutely. And to make sure that all the facilities are working together and collaboratively, because it is a little bit more difficult with a splintered plan. So we're hopeful in the next coming months that all the other counties will be starting to implement their MAT programs as well.
Yep. So the continuum of care also has been an issue for us in Hampden County. As Rachelle mentioned, for scheduled releases, I think we've had that covered. We've worked with a lot of good partners over the years, Spectrum Health, who's been really a great partner, and we've been working with for a number of years on some of the SAMHSA grants in addition to our Bay State Medical Bridge program. So for folks that have scheduled releases, whether they're staying within the county or going back to the Worcester County area, we've had really good success with the scheduled releases. It's the unscheduled releases, as Tara and Rachelle mentioned, that we have the problems with. The bridge scripts, that's something we've worked well with now through one of our other partners, Behavioral Health, who's CODAC has contracted with in Hampden County to assist with the discharge plan in addition to Spectrum Health and Bay State Bridge. The challenge is having folks be able to get same-day dosing or next-day dosing for those unexpected releases at court. So we continue to work through that, meeting with our community partners in that aspect. Med verification has also been a challenge. We have mass packs, so if they're in Butte, we can find that out. However, for our methadone programs are closed, and most of our intakes usually come later in the afternoon and at night. So verifying methadone is usually later in the day. So we're just developing systems, and I know that's being worked on in Massachusetts currently to sort of fine tune that process. But just a continuum of care and health insurance, that's the other barrier, huge barrier, where folks in Massachusetts, whether it's Mass Health Program, Medicaid, Medicare care, they're turned off when they're with us in corrections, and it's a challenge at times getting the services and the coverage turned back on. So it complicates things in scheduling appointments and community appointments for a lot of the folks who return to the community. So that's an area I know we continue to challenge the Mass Health group with, and trying to find a system of coverage that works as folks are transitioning back to the community and scheduling those appointments for our community providers.
Rich, thank you for that. I just wanted to kind of build on that quickly. The issue of insurance coverage being suspended, I heard great conversation on that yesterday, and we certainly do need to change it. In the meantime, what CODAC Behavioral Health Care has done, when someone comes out, they come into treatment, whether or not their Medicaid switch has been flipped or not. And I think that what is really important to know, and our CFO is back in the office probably shivering in her seat, but she hasn't updated me, so I'm going to use this number. Since we started accepting folks directly from incarceration, regardless of whether or not their Medicaid has been re-upped, we have only had 5 episodes of unreimbursed treatment, because Medicaid will reimburse retroactively. It is not, we have proven it is not a huge risk, as long as your cash flow can handle it from a vendor perspective or from whomever in the community. I think this is an important point when you're talking to those vendors, those wonderful vendors you have in Massachusetts, to let them know that that is not, it has proven to not be a risk. And I actually think that for our experience, Mass Health has been a bit quicker in responsivity. So that's a really important point. Now, we need to get rid of the suspension thing, and if you can make political will happen for that, God bless all of you. And but in the meantime, it is not a big a risk to the providers in the community as it feels, because the feeling around it seems to be greater than the actuality. Did anybody else want to speak to the Medicaid piece? And waivers, Dr. Clarke, you have spoken that waivers have been available to your knowledge?
They're not available yet. I know New York State has an application in. There are, Medicaid does have some exceptions for discharge planning 30 days prior to release, but I've been working closely with our state Medicaid, trying to nudge them along to try and get more services in, especially for the pretrial population.
And as others were also talking about, working with your provider partners in the community to enhance reentry. What we have learned, and this is just a practical tip, is that it is absolutely necessary. It's more than a phone call or one meeting of supervisors, you know, in order to have that partnership so that there is continuity of care for those reentering the community. Those relationships have to be nurtured and updated continually. It's one thing for me and Dr. Clarke, you know, to meet and talk about what we want to have happen. It's another thing for the discharge planner to call a provider's front office and get it to be real. I'm looking at Loran Howard here. I know that she's worked really hard on that in Rhode Island. So we have to, when you're working in the community, you know, whatever it might happen to be, we have all these kinds of agreements of cooperation. They have all different names, but it needs to be more than a piece of paper that's on the shelf. And once you have those connections, they need to be nurtured because people change through attrition all the time. Numbers change, sites change. And it sounds like a small thing, but it's not a small thing if somebody is reentering the community and the discharge planner has been trying for 3 days to get them connected before they leave.
I would agree. I would add to that as well. Being in Boston, we're very fortunate to have amazing hospitals. We have great relationships with Boston Medical Center and Mass General Hospital, as well as Boston Healthcare for the Homeless, which is connected to the Health Commission, as well as Boston Medical Center. But knowing where your bridge clinics are, or knowing if hospitals have bridge clinics, because if you cannot make somebody an appointment, at least you can give them the tools to say if you can go to, for us, Mass General Hospital, and walk into their bridge clinic. Giving them all the tools that they can have, that you know that you can hand them before they go to court, to say, what if, you know, if you don't come back, here are your options so you can get your dosing. And Mass General Hospital and Boston Medical Center cannot say enough for their partnerships, but they're knowing where your bridge clinics are. If you're in an area where there are either health clinics or hospitals that have them, it's integral to know that, to be able to share that with the men and women you're serving.
And at Norfolk County, we actually started handing out a packet with a list of every clinic throughout Massachusetts that DPH provided to us on day one. That way, if they do leave, often we do have guys that just go to court and we never see them again. So at least we're providing them with that list and they can take that. And we also added a last dose letter. Even though we're not an OTP, we added our own facility last dose letter, and we do it for Suboxone and Methadone. So we give that to them in the morning. So at least they have that, and it has our contact information so they could call our nursing staff if needed.
That's great. Thank you.
And we've done the same thing in Hampden County as far as the last dose letters and also packets for the patients with all the drop-in centers that they can go to in addition to the information to contact or nursing staff 24/7 with any questions. It's been going great. I know as far as the notification, we get a lot of calls in the community for those documents. One thing that was mentioned earlier, and I want to really circle back to, is having your staff buy in from the get-go. And I know when we started exploring, we had all disciplines at the table, security, the treatment, mental health, the education team or IT departments. You have to have staff bought in from the get-go if that's the direction you're looking to go with MAT within the walls of corrections. Within my 28 years of correctional experience, I know I've been quite fortunate to have a progressive sheriff for 40 years. pre his retirement 3 years ago, and it was instituted in all of our Correctional Officers Academy, all of our annual in-service trainings, where all these topics are covered: MAT, mental health, just a total well-being of our population. So having folks bought in from the beginning makes it a lot easier when you roll out your programs.
And I heard two things yesterday, thanks Rich, that kind of support that. Dr. Pete Friedman was referencing about 10 years ago, he was presenting and literally got booed off the stage at a professional conference this way for what he was talking about, his research and the importance of having this disease treated while someone was incarcerated, and that was just 10 years ago. And Dr. Robinson, I don't know if she's still here. There she is. We had a conversation yesterday that she recently had a presentation at a conference similar to this and had one full table walk out on her. So the cool thing is everybody else in the room stayed and was receptive. So we've seen a huge change over 10 years, but we still have the fear, the bias, and the discrimination, because that's really what stigma is, right? I'm quoting actually our past director of BHDDH, when we say stigma, it doesn't we don't feel it, but it's bias, it's fear, and it's discrimination. And that's what happens. So we've come a really long way from, being booed off the stage to just having a few people leave. But the importance comes, we've learned with that when people have fear-based beliefs, we really have a lot of trouble changing those, but many people have beliefs on their experience, and learning more becomes part of their experience. So the education is huge in shifting that culture. So thank you for bringing that up. Lastly, for me, I have a question. Again, I think it goes down to Dr. Clarke, if that's okay. The follow-up figures, because I've heard you speak before about the importance of immediate intervention, what an opportunity that is upon commitment, and what I don't recall what our follow-up stats actually are at this point in Rhode Island.
So we have I break it down into three populations. The first is people coming in on MAT. We continue those individuals, and the follow-up rate, believe, was 95%. It's probably higher because that doesn't include people who are out of state. And again, Rhode Island's so small, it's hard not to step out of state occasionally. The other population were people pre-release who are not on MAT but want to be on MAT. It took us a while to build up that part of the program, and early on we didn't have people on therapeutic doses necessarily when they left. We thought we could start 3 months before release, but then the good time date would get closer and closer. So the follow-up rates for that population were about 50%, which doesn't sound great, but if you think about what they would have been without a program, it would have been even less. The most difficult population was the population coming in, withdrawing from opiates in the community, and then being started on the MAT program. For those individuals, the follow-up rate was around 30 to 40%. If you think about it, it's not people coming in for treatment. They didn't volunteer to come into jail, and a lot were released within 48, 72 hours. So at least we are introducing people to the idea of treatment. And I know Leslie's told me about patients, and sometimes they'll come in 3 or 4 times over the years, and it's the 4th or the 5th time that it makes a difference for that individual, and then they're able to engage in recovery.
Thank you.
The other thing is the screening tools that are used, and I advise you to check in with your Department of Public Health and DCP and DEA regulations starting up, because a lot of the information is usually captured at the initial intake and assessment for us, which gets the whole process going. But that screen and whatever screening tools you use, it makes a huge difference for all the end users going forward. In addition to, I know in Massachusetts, J-Coin will be the evaluators of this pilot program, and that's with Bay State Medical, UMass Med School, and Tufts University will be doing the research for the pilot program. So keeping good documentation and uploading information to the required systems also helps us to take a look at what we're doing and make sure we're doing the correct thing, and can we do it better and enhance what we're doing.
Just going to add our experience with screening. At first, I thought we're going to use this evidence-based screening form, the TCU-5. It's not too long, but it's, 10, 15 questions? We found we were getting as many people by just asking the question, have you used opiates? So we went away from the formal screening questionnaire. We still do it for other substances, but anyone who says yes to the question, have you used opiates, is referred to the CODAC program. So then they do a full assessment. So not everybody that we send to CODAC ends up on MAT, but it really saved a lot of time for the nurses during the intake process. I'm not being down on evidence-based screening questionnaires. It was just, for us, it seemed we were getting the same number of people, and it might be because the patients eventually knew that if they say yes, then they're more likely to be offered treatment.
Great. So anything more anyone would like to add here before we move to questions?
I also want to say, in the process, you probably will adjust your systems 4, 5, 6, 7 times to get it correct.
700.
And I know recently we've made a number of changes, following some meetings with our Department of Public Health and our Bureau of Substance Abuse Services regarding continuation and the timeline and the window, how that looks. When we started the program, we were doing continuations with folks that maybe there's been a 5-day break from their home or guest dosing agency. Looking at our numbers and our stats and what we're seeing, we've now pushed that back 30 days. So we can do continuation and maintenance with folks that are coming in and may not have been dosed within that window. So that's one of the huge changes we've made recently within the last month to continue the services with the continuation, the maintenance, and having it be guest dosing. So that's something also that with the guidelines within your state and the agencies you're working for. And
thank you. One last point, I think, as well, as we've talked a lot about community partnerships. And I think the broader picture is none of this, this is huge culture change and systems change, not just internal for corrections, but for communities. So the collaboration has to be at every level. And at one presentation, I think we had a slide that showed parallel process, what needs to be happening at every level at the same time, and replicating that relationship from the state level to local levels of community into relationships with providers, and the education that has to happen everywhere, including for those that are receiving our care. So I guess basically we can never miss an opportunity to be an ambassador for this life-saving work.
Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorder. To request technical assistance, visit opioidresponsenetwork.org.